Step cycle will stop when energy requirement is fulfilled. Now this citrate, which is present in this mitochondria, want to come out of the mitochondria. It will come out of the mitochondria by a citrate shuttle. So citrate transporter, with the help of this transporter, citrate come out in cytosol. Now this citrate is again converted to acetyl coenzyme A. So I can say this acetyl coenzyme A, which was present in mitochondria, reaches cytosol with the help of citrate. That's why it is called citrate shuttle. So now we start fatty acid synthesis. Till now, I told you how extra carbohydrate is converted to fat, means extra carbohydrate, glucose, ultimately converted to acetyl coenzyme A. Now this is the starting point of fatty acid synthesis. So first step or rate limiting step in fatty acid synthesis is acetyl coenzyme A to malonyl coenzyme A. Acetyl coenzyme A is having 2 carbon, malonyl coenzyme is having 3 carbon. A 2 carbon compound is converted to 3 carbon compound. 1 carbon must be joined. So joining of carbon dioxide. So you will join carbon dioxide, and joining of carbon dioxide is called carboxylation. So that's why the name of enzyme is acetyl coenzyme carboxylase. And you know the rule of carboxylase, mnemonic A, B, C. A for ATP, B for biotin, C for CO2. So cofactor for this carboxylase is biotin, and in this ATP is used. When ATP is used, other name for the same enzyme is malonyl coenzyme synthetase. Not synthase, synthetase. ATP is used. Synthase, no ATP used. Synthetase, even in pronunciation you require more energy. ATP is used and malonyl coenzyme is produced. Because malonyl coenzyme is produced, that's why it is called malonyl coenzyme synthetase. And we know that this malonyl coenzyme A is inhibitor of CPT1. What is CPT1? We will discuss with beta oxidation of fatty acid. For the time being, this malonyl coenzyme synthetase or acetyl coenzyme carboxylase is the rate limiting enzyme of fatty acid synthesis. So in fatty acid synthesis, we have synthesized malonyl coenzyme till now. So now I can say in cytosol, I am having malonyl coenzyme and I am also having acetyl coenzyme. So cytosol is having acetyl coenzyme and few acetyl coenzyme has been converted to malonyl coenzyme. Acetyl 2 carbon, malonyl 3 carbon, and the rate limiting enzyme is malonyl coenzyme synthetase or acetyl coenzyme carboxylase. Now further synthesis of fatty acid will take place on fatty acid synthase complex. The next enzyme is multi-enzyme complex. This is fatty acid synthase complex. First question, fatty acid synthase complex is multi-enzyme complex. Multi-enzyme complex. And it is a dimer. It is a dimer. And each monomeric unit is having 6 enzymatic activity. Question is asked, each monomeric unit is having 6 enzymatic activities. Okay, and when you see the structure of this dimer, it will look like X. So X-like. So X-like structure, X-like. So question on fatty acid synthase complex. First question, it is a dimer, it is multi-enzyme complex, and each monomeric unit is having 6 enzyme and the shape is X. And this is the main enzyme. Point it out. I write here main enzyme. If question is asked, what is the rate limiting enzyme of fatty acid synthesis? Then this is rate limiting enzyme. But if they ask what is the main enzyme, then it is fatty acid synthase complex. This is complex structure, so we will simplify the structure of this fatty acid synthase complex like this. I told you fatty acid synthase complex is a dimer. This is one subunit. This is second subunit. So we found that this is simplified structure of fatty acid synthase complex. We were having acetyl coenzyme in cytosol. We were having malonyl coenzyme in cytosol. So now acetyl coenzyme will come and bind to this fatty acid synthase complex. Malonyl coenzyme may bind with to this fatty acid synthase complex. Now this acetyl and malonyl is attached with fatty acid synthase complex. Now there would be condensation reaction. These will join. Acetyl 2 carbon will join with malonyl 3 carbon, 2 and 3 5 carbon. Out of 5 carbon, 1 carbon will be removed. Removal of carbon dioxide, and there would be formation of ketoacyl. What is the name of compound? Ketoacyl is synthesized. That's why the name of enzyme is ketoacyl synthase. And this reaction is called condensation reaction. Condensation means these two units are condensed. When they are condensed, 1 carbon is removed. C4 condensation, C4CO2. Frequently asked question in fatty acid synthesis. In condensation reaction, CO2 is removed. What is the name of enzyme? Ketoacyl synthase, KAS. कसा, condense किया, कस दिया हमने. So condensation reaction, ketoacyl synthase. Now 4 carbon compound is formed. Now this 4 carbon compound will be converted to butyric acid. Butyric acid is 4 carbon fatty acid. So I want to make 4 carbon fatty acid. I started with acetyl coenzyme having 2 carbon. I converted acetyl to malonyl coenzyme having 3 carbon. Now 1 acetyl. Yes, in cytosol other acetyl coenzyme are also there. So 1 acetyl and 1 malonyl coenzyme bind with this fatty acid synthase complex, then condensation reaction occur and CO2 is removed and a 4 carbon compound is formed. Now this will be acted upon by 3 enzymes. You must remember the sequence. Exact name, if don't remember, it's okay, but reductase, dehydratase, reductase. Ketoacyl reductase, and you know wherever reduction is required you use NADPH, and this NADPH come from HMP shunt, frequently asked question, and cytosolic isocitrate dehydrogenase. Point it out. If isocitrate dehydrogenase is present in mitochondria in Krebs cycle, it produces NADH. But in cytosol, isoenzyme isocitrate dehydrogenase produce NADPH. So NADPH produce another malic enzyme. They produce NADPH, which is used in fatty acid synthesis. Which enzyme? Ketoacyl reductase. Question is asked. Now dehydratase. How you will remember this sequence? CAR. KAR. Ketoacyl reductase. Yes, wiper on the car goes swish, 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 water is removed. Dehydratase. Now engine oil is also reduced in your car. Engine oil reductase, in oil reductase. And whenever reductase, you require NADPH. Again, NADPH. So reductase, dehydratase, and 4 carbon fatty acid, butyric acid is produced. Question is asked, in fatty acid synthesis, in first cycle, how many carbon fatty acid produced? 4 carbon fatty acid produced. Again, I am repeating, in first cycle of fatty acid synthesis, 4 carbon fatty acid, butyric acid is produced. In further cycle, in each and every cycle, you will add 2 carbon, 2 carbon, 2 carbon, means 4 to 6, 6 to 8, 8 to 10, 12, 14, 16. Palmitic acid, yes, palmitic acid. So ultimately, palmitic acid is produced. So in fatty acid synthase complex, main enzyme, you will remember, out of 6 enzyme, 4 enzyme I told you that ketoacyl synthase, 3 enzyme reductase, dehydratase, reductase. And now the 5th enzyme I am going to tell you, thioesterase. Only 1 enzyme left. Otherwise, I have told you out of 6 enzymatic activity, 5 enzyme I have told you. Thioesterase release palmitic acid from this fatty acid synthase complex. So this fatty acid synthase complex, ultimately most common fatty acid synthesized on it is palmitic acid. Question is asked, most common fatty acid synthesized in our body is palmitic acid, and this is released by which enzyme? Thioesterase. Ustra, if you know that old movies, Ustra is sharpened like this, palm on palmitic acid. So most common fatty acid to be synthesized, and in each cycle, other than first cycle, in each cycle you join two carbon atom. In this way, fatty acid is synthesized. Now we discuss ketone body synthesis or ketoacidosis. Ketoacidosis, you all have heard many times. Diabetic ketoacidosis, starvation ketoacidosis, and you know these ketoacidosis is a very toxic condition. Whenever ketone bodies are so toxic, why body is synthesizing? Because you know, in starvation, diabetes, these ketone bodies are produced, and these ketone bodies are food for most vital organ, brain, heart, and skeletal muscle. You know, most vital organ, brain and heart and your skeletal muscle utilize ketone body in starvation. That's why in starvation, body you synthesize or liver synthesize ketone body, because liver is the main organ of metabolism. It is the responsibility of liver to synthesize ketone body for these most vital organs. So ketone body synthesis occur in liver, and this occur in mitochondria. So ketone body synthesis, I will start from acetyl coenzyme. Two molecules join to form acetoacetyl coenzyme. This acetoacetyl coenzyme is further converted to HMG coenzyme by enzyme HMG coenzyme synthase, and this is rate limiting enzyme of ketone body synthesis. So in ketone body synthesis, till now I have told you rate limiting enzyme, that is HMG coenzyme synthase. This HMG coenzyme A is converted to acetoacetate by HMG coenzyme lyase. It will be cut and it will produce acetoacetate, first ketone body to be synthesized. Question is asked, this is the first ketone body to be synthesized or primary ketone body? Mnemonic A, first alphabet. A, first alphabet, so first ketone body. This acetoacetate is further converted to beta hydroxybutyrate, and this acetoacetate is also converted to acetone. So there are three compounds which are termed as ketone body: acetoacetate, beta hydroxybutyrate, and acetone. Acetoacetate is the first ketone body. It is called primary ketone body. And these beta hydroxybutyrate and acetone, they are secondary ketone bodies. And beta hydroxybutyrate is most common ketone body present in blood. How you remember? B for big amount, large amount. They will give you clinical scenario and they will say that patient is in starvation. Which of the following ketone body will be present in largest concentration? Beta hydroxybutyrate. So these are ketone bodies. Now question is asked, first ketone body to be synthesized is acetoacetate. Most common ketone body present in blood, that is beta hydroxybutyrate, बहुत सारी, big amount. To detect ketone bodies, we have Rothra's test. In Rothra's test, we get purple color ring. So Rothra's test is done for detection of ketone bodies, and a positive Rothra's test is when purple color ring is seen at junction of two liquid, means purple color ring would be there. Image based question has been asked. How you will remember? By mnemonic: ketone as stone, Rothra throw, propel पर्पल एज प्रोपेल. जिनके घर शीशे के होते हैं वो दूसरों के घर पर पत्थर नहीं फेंकते. तो फेंकते मीन्स थ्रो, propel, stone. So ketone, Rothra's, propel. We know that ketoacidosis occur in both diabetes and starvation. So in both diabetes and starvation, Rothra's test would be positive. But in diabetes, blood glucose is high. So this glucose will be filtered and will come in urine. And glucose is reducing sugar, and reducing sugar give Benedict test positive. So if a patient comes to your emergency and having ketoacidosis, you can easily differentiate if urine is having Benedict test positive. Bandic test positive means glucose is there in urine, that is diabetes. But if patient is in starvation, not taking food for a long time, glucose is low, how can it come to urine? So Bandic test would be negative in starvation. Now, ketone body utilization. Ketone body utilization, first step is acetoacetate is converted to acetoacetyl coenzyme A, and in this reaction succinyl coenzyme A is converted to succinate, and the name of enzyme is thiophorase. This is the rate limiting enzyme, and this enzyme is absent in liver. Yes, liver is Yogi Purush, Mahatma. Liver synthesize ketone body, but don't utilize ketone body. Liver is the organ which synthesize ketone body, but can't utilize ketone body due to deficiency of which enzyme? Thiophorase. Yes. So question is asked, liver is the organ which can synthesize ketone body, but can't utilize ketone body due to deficiency of thiophorase, and this ketone body acetoacetate, first ketone body to be synthesized, I metabolized and converted to acetoacetyl coenzyme A. It is further converted to acetyl coenzyme by enzyme thiolase. This acetyl coenzyme A will go Krebs cycle, one acetyl coenzyme A enter TCA cycle, T4, TCA, T4, 10 to produce 10 ATP, 10 ATP, one acetyl coenzyme A, So this is ketone body utilization occurring in brain, heart, and skeletal muscle. Liver synthesize ketone body but can't utilize ketone bodies. Now we discuss beta oxidation of fatty acid. We know that beta oxidation of fatty acid occur in starvation and diabetes. In starvation, you are not taking diet. There is no glucose to produce energy. Cell will utilize fatty acid to produce energy by beta oxidation of fatty acid. In diabetes, blood glucose is high but will not enter the cell. When glucose will not enter the cell, cell will think there is no glucose. It will utilize fatty acid to produce energy by beta oxidation of fatty acid. So beta oxidation of fatty acid occurs in starvation and diabetes. We have just discussed that ketoacidosis, diabetic ketoacidosis, starvation ketoacidosis. So ketoacidosis occurs in starvation and diabetes. And we have discussed in carbohydrate that gluconeogenesis occurs in starvation and diabetes. So these three pathways occur in starvation and diabetes, frequently asked question. And we will discuss shortly that beta oxidation occurs in mitochondria. Oxidation, looks like mitochondria. So beta oxidation occur in mitochondria. We have just discussed that ketone body synthesis also occur in mitochondria, and we have learned this by mnemonic also, that hug pyari heme synthesis, H for heme synthesis, U for urea cycle, G for gluconeogenesis, pyari for pyrimidine synthesis occur both in mitochondria and cytosol. So gluconeogenesis first step occur in mitochondria. So you can say these three pathway occur in same compartment or start in same compartment and occur in same condition, means they must be having some relation. Kuch na kuch to hai daya, CID. And on this relation, questions are asked. So we start with beta oxidation of fatty acid, then we will explore the relation and clinical question asked on this relation. First, we start beta oxidation of fatty acid. First of all, fatty acid is activated. Yes, fatty acid will produce large amount of energy, just like palmitic acid. Palmitic acid, we all know palmitic acid, how many carbon atoms are there? 16 carbon atom. And if I do complete oxidation of palmitic acid, complete oxidation, O for oxidation, and I put this O here, 106. So net gain of ATP 106 ATP from palmitic acid. First question, Most common fatty acid which is oxidized by beta oxidation is palmitic acid. And most common fatty acid which was synthesized was again palmitic acid. So palmitic acid is synthesized and oxidized most commonly. So palmitic acid will be oxidized in mitochondria and net gain would be 106 ATP. First of all, you have to activate this palmitic acid. Activation of fatty acid. So before going for beta oxidation, it should be activated, just like you will give him Mountain Dew. He is afraid to go inside the mitochondria because he knows that whenever I will go, I will die, be oxidized. So you will give him Mountain Dew. डर के आगे जीत है. Now he is activated. And in this activation, you require 2 ATP. Means fatty acid is activated, fatty acid is converted to acyl coenzyme A. In this, ATP is converted to AMP. When ATP is converted to ADP, one high energy phosphate is used. When ATP is converted to AMP, two high energy phosphates are used, equivalent to 2 ATP. And the name of enzyme is acyl coenzyme A, acyl coenzyme A synthetase, synthetase ATP is used. Now, this fatty acid want to enter the mitochondria. But you know, inner mitochondrial membrane don't allow each and every compound to enter. So this fatty acid will say, how I go inside the mitochondria? We said, don't worry. You are activated. You are willing. I will give you a car of James Bond. So we gave here a car. Carnitine. Frequently asked question, fatty acid enter the mitochondria with the help of compound carnitine. Now, other than carnitine, you also require petrol for this car. So one enzyme CPT1 is also required. So we are doing transport of fatty acid. First of all, we activated this fatty acid, activation of fatty acid, 2 ADP were used. Now we transport it from cytosol to mitochondria. And we found that to transport this from cytosol to mitochondria, we require 3 enzymes. Those are CPT1, that is carnitine palmitoyl transferase 1, CPT2, carnitine palmitoyl transferase 2, and translocase carnitine acyl carnitine translocase. So I can say till now I have discussed 4 enzymes. Out of these 4 enzymes, first enzyme is acyl coenzyme A synthetase, or another name is thiokinase. And CPT1, that is present at outer mitochondrial membrane. You can easily remember. Yes. Now, we found that CPT2 and translocase are present at inner mitochondrial membrane. How you will remember that translocases are present at inner mitochondrial membrane? We have discussed in electron transport chain, ADP ATP translocase is present at inner mitochondrial membrane. In the same way, carnitine acyl carnitine translocase is also present at inner mitochondrial membrane. Now, this fatty acid, this palmitic acid entered the mitochondria with the help of this CPT1, carnitine, CPT2 and translocase, and this CPT1 is important. This is rate limiting enzyme of beta oxidation of fatty acid. Sometimes we say this is the gate. This is the gateway of beta oxidation of fatty acid. Means with this enzyme, this fatty acid will enter the mitochondria, and when it will enter the mitochondria, it will be oxidized. How this beta oxidation occur? This is palmitic acid having 16 carbon. Beta oxidation means a cut between C2 and C3. A cut between C2 and C3. This cut is done by 4 enzymes. First is dehydrogenase, second is hydratase, third is dehydrogenase, fourth is thiolase. Or you can say dehydrogenase or acyl coenzyme dehydrogenase. Acyl, I told you, fatty acid group name is acyl. So this is acyl coenzyme A. So name of dehydrogenase is acyl coenzyme A dehydrogenase. And you know rule, wherever dehydrogenase is there, hydrogen is removed. Hydrogen is taken up by FAD to form FADH. Whenever dehydrogenase act, hydrogen is removed and it is taken by NAD to form NADH. Mnemonic. First dehydrogenase produce FADH. F4 first, F4 FADH. Second dehydrogenase produce NADH. You know that this FADH enter electron transport chain to produce 1.5 ATP. This NADH enter electron transport chain to produce 2.5 ATP. And in this way, this bond is cut and there is production of 1.5 plus 2.5, 4 ATP. So you can say by this one cut, we produce 4 ATP, and by this one cut 2 carbon unit comes out as acetyl coenzyme A. Palmitic acid is having 16 carbon. Palmitic acid is having 16 carbon. So you can say number of acetyl coenzyme A which can be produced 16 by 2. Yes, 2 carbon unit from 16 carbon compound, you can produce 8 acetyl coenzyme A. 8 acetyl coenzyme A. By how many cut? You can count. First cut, second cut, third, fourth, fifth, sixth, seventh. Seventh cut will produce 8 acetyl coenzyme A. 7 cut. And you know that 1 acetyl coenzyme A enter Krebs cycle to produce 10 ATP. So 8 acetyl coenzyme A will enter Krebs cycle to produce 8 into 10, 80 ATP. One cut produce 4 ATP. I told you one cut produce 4 ATP. So 7 cut will produce 7 into 4, 28 ATP. But 2 ATP were used in the activation of fatty acid. 2 ATP used in activation. So net gain of ATP would be 80 plus 28. That is 108. Minus 2, 106 ATP. Complete oxidation of palmitic acid produce 106 ATP. So first function of beta oxidation, I told you production of energy, and complete oxidation of palmitic acid, there is net gain of 106 ATP. Sequence of this enzyme is important. Questions are asked. We will remember with the help of animation beta oxidation of fatty acid. First enzyme is dehydrogenase. He strike this X and dehydrogenase, hydrogen is removed. This is taken up by FAD to form FADH. Next, the name of enzyme is hydratase. It will join water. Hydratase. Now it becomes soft. Now it is strike again. It is strike again. Again hydrogen is removed. It is taken up by NAD to form NADH. Now only small part is left. Now he will do thiolase, thiolase, and 2 carbon units is released. So I discussed that beta oxidation of fatty acid, one function of this acetyl coenzyme A is to produce energy by Krebs cycle, TCA cycle. Another function of acetyl coenzyme A means 8 acetyl coenzyme produced. One function was energy production. Second function is acetyl coenzyme A is activator of pyruvate carboxylase. This is first step of gluconeogenesis. Pyruvate to oxaloacetate by pyruvate carboxylase. This is the first step of gluconeogenesis. So second function of acetyl coenzyme A is to activate gluconeogenesis. In gluconeogenesis, we synthesize new glucose, and in synthesis of new glucose, we require energy, and that energy also comes from beta oxidation. So I can say beta oxidation occur, energy is produced, and this energy is used for gluconeogenesis. This beta oxidation occur, acetyl coenzyme produce, this acetyl coenzyme may activate gluconeogenesis. So one function is energy production. Second function of acetyl coenzyme may activate gluconeogenesis, and third function we have just discussed that ketone body synthesis starting point is 2 acetyl coenzyme may join to form acetoacetyl coenzyme A, then HMG coenzyme A, then acetoacetate ketone body to be synthesized. First is acetoacetate. So acetyl coenzyme A, one function is ketone body synthesis. So 3 function I can enumerate here. If beta oxidation is defective, if this acyl coenzyme dehydrogenase is not functioning, what will happen? If beta oxidation will not occur, then energy will not be produced. 1 point. If beta oxidation is not occurring, then acetyl coenzyme A is not produced, so gluconeogenesis would not be there. There would be hypoglycemia. And whenever hypoglycemia is there, many time in clinical scenario, patient present with seizures. If beta oxidation is not occurring, acetyl coenzyme will not be produced, then there would be low ketone body. Ketone body would not be synthesized, decreased ketone bodies. Why I have discussed this point? Because recently question was asked if a patient is having carnitine deficiency. In carnitine deficiency, this fatty acid will not enter the mitochondria. When fatty acid will not enter the mitochondria, beta oxidation would not occur. When beta oxidation would not occur, energy will not be produced, gluconeogenesis would not be there, ketone body synthesis would not be there. So in carnitine deficiency, there would be hypoglycemia, there would be decreased ketone bodies. And whenever we do exercise require energy, and in muscle, energy is produced by beta oxidation of fatty acid. So if a person is having carnitine deficiency, then muscle will not be able to produce energy from fatty acid. So there would be accumulation of fatty acid because it will not be oxidized. This fatty acid will bind with glycerol to form triacyl glycerol. Point it out. This fatty acid, long chain fatty acid. Why I told you long chain fatty acid? I told you palmitic acid. I took example of palmitic acid, long chain fatty acid. This is a question that long chain fatty acid require carnitine, but medium chain fatty acid and short chain fatty acid, they don't require carnitine to enter the mitochondria. They go very easily. So we found that if carnitine is deficient, this long chain fatty acid will accumulate, will bind with cholesterol to produce triglyceride with long chain fatty acid. It will accumulate in muscle, and in muscle fat will accumulate, so fat vacuole. In muscle you can't do exercise, so exercise intolerance, muscle cramp would be there. So this question was asked in NEET page 24 clinical scenario. They gave fat vacuole was there, exercise intolerance was there, triglyceride with long chain fatty acid. What deficiency is this? Carnitine deficiency. Now medium chain acyl coenzyme A dehydrogenase. This acyl coenzyme A dehydrogenase is deficient, then beta oxidation would not occur. So I told you the same symptom, hypoglycemia and decreased ketone body would be there. In this patient, typical history, you will find that patient is not taking food for a long time, means starvation. When in starvation, this enzyme is deficient, so beta oxidation would not occur. This emergency case appeared in emergency department. You said that starvation is there, ketone body should be high, but in this ketone body is low. In starvation, ketone bodies are increased, but in this ketone bodies would be low. Yes, there is only one place in which medico usually see, in spite of starvation, politicians are not having increased ketone bodies because they eat behind the curtain. But here is the real situation, that where if patient is in starvation, this enzyme of beta oxidation is not working. So in spite of starvation, ketone body will not increase because beta oxidation is not occurring. So ketone body would be low and gluconeogenesis will not be there, hypoglycemia would be there. Jamaican vomiting sickness. In Jamaican vomiting sickness, ackee fruit unripe contain hypoglycin, a compound. This compound hypoglycin inhibit acyl coenzyme dehydrogenase, means beta oxidation. Yes, beta oxidation will not occur, and if beta oxidation will not occur, there would be hypoglycemia, decreased ketone body. The same scenario. Yes, all these three, the same things are happening. Beta oxidation is not working. That's why hypoglycemia, decrease ketone body, and we found that in this patient there would be vomiting because the name is Jamaican vomiting sickness. That may occur. In this, sometimes in clinical scenario, you will find dicarboxylic acidosis. Dicarboxylic acidosis is also there, although you will make diagnosis by simple concepts. But I told you. So this is about beta oxidation and its implementation. Now, cholesterol synthesis occur in cytosol. It occur in fed state. Fed state. Ketone body synthesis occur in mitochondria. It occur in starvation. We found that in cholesterol synthesis and ketone body synthesis, yes, although they are occurring in different situation, different compartment, cholesterol synthesis occur in cytosol, ketone body synthesis occur in mitochondria, but first two step I highlight, these first two steps are common to ketone body synthesis and cholesterol synthesis. Question has been asked, enzyme common to cholesterol synthesis and ketone body synthesis. Answer was HMG coenzyme A synthase. Thiolase was not given the option. Answer was HMG coenzyme. So acetyl coenzyme A joined to form acetoacetyl coenzyme A, then HMG coenzyme A. In cholesterol synthesis, the rate limiting enzyme is HMG coenzyme A reductase. This is rate limiting enzyme, and this HMG coenzyme A is converted to mevalonate. We found that drugs statin inhibit this HMG coenzyme A reductase and decrease cholesterol synthesis. Till now, we have discussed beta oxidation of fatty acid and fatty acid synthesis. We know fatty acid synthesis occur in fed state. Beta oxidation occur in starvation. So when you are in fed state, you are having sufficient amount of energy. Is there any need to do beta oxidation? No, there is no need of beta oxidation of fatty acid in fed state because beta oxidation occur in starvation. So we found that when fatty acid is being synthesized, this acetyl coenzyme is converted to malonyl coenzyme A. This malonyl coenzyme A is inhibitor of CPT1. And CPT1 is a rate limiting enzyme of fatty acid oxidation or beta oxidation of fatty acid. You know, if you want to do beta oxidation of fatty acid must enter mitochondria with the help of carnitine and CPT1. So if CPT1 is inhibited, beta oxidation will not occur in a fed state. So question is asked that when liver is actively synthesizing fatty acid, means manolin coenzyme A is being synthesized. There would be concomitant decrease in beta oxidation of fatty acid due to inhibition of CPT1 by malonyl coenzyme A. Sometime in question you will not find that inhibition of CPT1. They will say inhibition of transport of fatty acid from cytosol to mitochondria. This malonyl coenzyme A inhibit transport of fatty acid from cytosol to mitochondria by inhibiting CPT1. Now, beta oxidation of odd chain fatty acid. Suppose this fatty acid is having 7 carbon. Beta oxidation means a cut between C2 and C3. First beta oxidation, acetyl coenzyme A. Second beta oxidation, acetyl coenzyme A. And the end product would be propionyl coenzyme A. Propionyl coenzyme A, 3 carbon fatty acid. You know, fat are never substrate for gluconeogenesis. We have learned that carbohydrate can be converted to fat, but fat cannot be converted to carbohydrate. Carbohydrate can be converted to fat, but fat cannot be converted to carbohydrate. Exceptions, two exceptions. One is propionyl coenzyme A and another is glycerol. These are substrate for gluconeogenesis. Otherwise, fat cannot be converted to carbohydrate. Now we come to beta oxidation of very long chain fatty acid having carbon 22, 22 carbon, 20 carbon. This very long chain fatty acid, beta oxidation occur in peroxisome. So this very long chain fatty acid In this peroxisome, when beta oxidation will occur, there will be production of H2O2. This is peroxisome, so will produce peroxide, hydrogen peroxide, no ATP produced, no ATP produced. Now we come to alpha oxidation. It occurs in endoplasmic reticulum and peroxisome. Again, peroxisome. What is alpha oxidation? Alpha oxidation means cut between C1 and C2. Beta oxidation was cut between C2 and C3. Alpha oxidation between C1 and C2. And when this cut is done, this carbon is removed as CO2. And in this, no ATP produced, no ATP produced. So you can say in peroxisome, very long chain fatty acid, beta oxidation, no ATP produced. In peroxisome, yes, alpha oxidation, no ATP produced. Now question is asked on Refsum disease. In Refsum disease, there is defect in the alpha oxidation. And which fatty acid undergo alpha oxidation? Branch chain fatty acid, phytanic acid. Phytanic acid is branch chain fatty acid, first question. This phytanic acid is oxidized by alpha oxidation. And this alpha oxidation occur by enzyme phytanoyl coenzyme oxidase or phytanoyl coenzyme hydroxylase. If this enzyme is deficient, then it lead to Refsum disease. Questions are asked direct that enzyme deficiency is phytanoyl coenzyme oxidase or hydroxylase. In this, branch chain fatty acid metabolism is defective, and symptoms mnemonic R for retinitis pigmentosa, R for Refsum disease, R for retinitis pigmentosa. I remember it as I for ichthyosis. F for fibrillation, ventricular fibrillation or cardiac arrhythmia. Cardiac arrhythmia. Okay. So these are symptoms of Refsum disease. Now very, very important, Zellweger syndrome or cerebrohepatorenal syndrome. Frequently asked question, the name itself tells you cerebro means there would be CNS involvement, seizure would be there, hypotonia would be there. What is the defect? In this defect in PAX gene. In Zellweger syndrome, we found that this is peroxisome. In peroxisome, normally the enzyme which is synthesized in cytosol, this enzyme will enter the peroxisome by a targeting sequence that is called peroxisomal targeting sequence. When this enzyme is synthesized, now this enzyme will go to peroxisome with the help of peroxisomal targeting sequence. If this peroxisomal targeting sequence is defective, means this is address. With this address, this enzyme will go to peroxisome. If this is defective, then enzyme will not go to peroxisome. So peroxisome will not be able to do the function because peroxisome do function by enzyme. So if it will not do function, question is asked, there is deficiency of functional peroxisome or functional deficiency of peroxisome or functional peroxisome deficiency. Question has been asked. We found that in this peroxisome, very long chain fatty acid is oxidized. So if this enzyme will not reach, this will not be oxidized. So this very long chain fatty acid will increase. So in lab diagnosis, there would be increased very long chain fatty acid. This is Zellweger syndrome, cerebrohepatorenal syndrome. Lipids are defined as not soluble in water and soluble in organic solvent. Means we define lipid on the basis of physical property. If you take one oil drop and put in water, it is not soluble. In the same way, lipids are not soluble in blood. So when lipids are not soluble in blood, it is really difficult to transport lipid via blood. We will discuss in detail how these are transported. For the time being, lipids are insoluble in blood. Lipid may be simple lipid. Simple lipid is made up of only alcohol and fatty acid. Alcohol, example of alcohol is glycerol. I usually remember glycerol as E. E having each arm is having OH, OH, OH. And these each arm attach with fatty acid, fatty acid, fatty acid. And group name of fatty acid is acyl. So one acyl, second acyl, third acyl. Triacyl glycerol. This is glycerol. So simple lipid, one example is triacyl glycerol. Another name is triglyceride. Another name is neutral fat. Neutral, it is neutral. It is not amphipathic. And triglyceride is most important fat stored in our body, or fat is stored in our body in the form of triglyceride. Fat is stored in which form in tissue? That is triglyceride. Question is asked. Other example of lipid is phospholipid. Phospholipid may be phosphatidylcholine or lecithin. Phosphatidylcholine or lecithin. One example. And if lecithin or phosphatidylcholine is deficient, then it lead to respiratory distress syndrome. You know, dipalmitoyl phosphatidylcholine is a part of surfactant. Second example of phospholipid, cardiolipin. Name itself tells you it is present at inner mitochondrial membrane. First question. Bar syndrome. Car cardiomyopathy. So Bar syndrome, cardiomyopathy. In Bar syndrome, there is a defect in the cardiolipin remodeling. So if cardiolipin remodeling defect, that is Bar syndrome and lead to cardiomyopathy. We found that this act as receptor for cholera toxin in intestine. Now we come to lipoprotein. As I told you, lipids are insoluble in blood. So lipids should be transported via blood in the form of lipoprotein. We know proteins are having charge. They are polar. They are soluble in blood. So we attach lipid with protein to make lipoprotein. Now lipid can be transported in the form of lipoprotein. Lipoprotein may be chylomicron, VLDL, VLDL remnant, LDL, HDL. Questions are asked on the size. Maximum size chylomicron and smallest size of HDL. HDL is smallest and chylomicron largest. We found that maximum content of lipid is present in chylomicron. You know, lipids are light, L4 lipid, L4 light, while proteins are dense. Proteins are dense. So HDL means high density lipoprotein. HDL means high density lipoprotein. So in HDL, you will find maximum protein and maximum density. So we can say density and protein are maximum in HDL, and minimum in chylomicron. Size maximum in chylomicron and lipid maximum in chylomicron. So you can say size decreases when you go from chylomicron to HDL. Size decreases, density and protein content increases. Size decreases, lipid decreases, density and protein increases. So this is about different types of lipoprotein and their characteristic. We know that lipids are light. Why light? Because you know butter float over buttermilk because it is light. And if you do electrophoresis of these lipoprotein, then you will find that chylomicron will move least and HDL will move maximum. HDL highest mobility, CM chylomicron कम, सबसे कम movement. So you will remember least movement chylomicron, maximum movement HDL on electrophoresis. Now chylomicrons are synthesized in our intestine whenever we take diet. In our diet, triglyceride is there. Dietary triglyceride, that is called exogenous. exogenous triglyceride. Whenever we take food, this exogenous triglyceride go to intestine. Intestinal mucosal cell synthesize a lipoprotein that is called chylomicron. So first question, chylomicron are synthesized in intestine. When we saw the structure of this chylomicron, we found that chylomicron contain triacylglycerol, which is exogenous, means coming from diet. And it contain one apoprotein, that is ApoB48. Now this chylomicron is thrown in blood, means the main purpose of chylomicron is to transport dietary lipid. Whatever triglyceride you ate, that will be transported via blood within the form of chylomicron. When this chylomicron will move via blood, it will be acted upon by enzyme lipoprotein lipase. Lipase cut lipid. When lipase will cut this triglyceride or triacylglycerol, it will release fatty acid. So we found that chylomicron was having large amount of lipid, triglyceride. And now when it is moving via blood vessel, it is metabolized with the help of lipoprotein lipase and fatty acids are removed. And when fatty acids are removed, it becomes chylomicron remnant, means remnant part of chylomicron. After removal of so many fatty acid, the remnant part is called chylomicron remnant. And this conversion is done with the help of lipoprotein lipase. And we found that ApoC2 is activator of lipoprotein lipase. We found that chylomicron contain mainly triglyceride. So if I say in any disorder, if chylomicrons are increased, you will say triglycerides are increased. But we found when the composition of chylomicron remnant, we found it contain both triglyceride and cholesterol. So if chylomicron remnant are increased, you will say triglyceride and cholesterol both are increased. So in any disorder, if chylomicron remnant are increased, you will say both triglyceride and cholesterol increased. Clear? So mnemonic, chylomicron single word, only one type of lipid is increased. Chylomicron remnant, two words, both triglyceride and cholesterol are increased. Okay. Now, if chylomicron remnant is further metabolized, it will be metabolized with the help of ApoE, apoprotein E. ApoE, with the help of this, chylomicron remnant are metabolized with the help of ApoE. ApoE. So question is asked, liver take chylomicron remnant with the help of ApoE. So if ApoE is defective, then chylomicron remnant will not be metabolized. Point it out. If lipoprotein lipase is defective, then chylomicron will not be metabolized. If ApoC2 is defective, then chylomicron will not be metabolized. Again, I am repeating. If ApoC2 is defective or lipoprotein lipase is defective, then chylomicron will not be metabolized. So chylomicron will be increased in blood, and that is called familial hyperchylomicronemia. So type 1 hyperlipoproteinemia, another name is familial hyperchylomicronemia. In this defect in lipoprotein lipase or ApoC2 defect. If lipoprotein lipase or ApoC2 is defective, then chylomicron will not be metabolized. Chylomicron will increase in blood. When chylomicron will increase in blood, chylomicron contain triglyceride. Triglyceride is increase in blood. Chylomicron is increase in blood. Because chylomicrons are increased, that's why it is called familial hyperchylomicronemia. And you will remember that chylomicron contain triglyceride, and triglyceride I remember as white butter. So you will remember white butter as triglyceride, and whenever triglyceride is increased, you will find white color. So in this hyperlipoproteinemia type 1 or hyperchylomicronemia, when you will take blood sample, you will find milky white plasma because triglyceride or chylomicrons are increased. So milky white plasma. Sometimes in question, in place of milky white, they will give the word lactation. Lactation matlab milk. Sometimes they will give, if you keep the sample at 4 degrees centigrade overnight, there would be supernatant layer of white color. That is supernatant layer of white color that is in type 1 hyperlipoproteinemia. You know that cream of tomato soup appearance in few question you will find. Triglyceride is just like cream, white cream. Tomato soup, just like blood. So in blood, if triglyceride is increased, it appears cream of tomato soup appearance. And when you find triglycerides are increased, lipids are increased, and you do fundoscopy, you will find this whitish hue in fundoscopy. Normally in fundoscopy, you will find reddish, but now here there is whitish. This is called lipemia retinalis. And when triglycerides are increased, they will deposit. So you know that this butter is granular, so mnemonic. If you deposit this granular compound here, yes, if you deposit this granular thing here, it would be eruptive xanthoma. So now I can say type 1 hyperlipoproteinemia or familial hyperchylomicronemia. Defect is lipoprotein lipase or ApoC2. In this, chylomicron will not be metabolized. So chylomicron will increase. That's why it is called familial hyperchylomicronemia. In this, triglyceride will increase. Due to increased triglyceride, there would be cream of tomato soup appearance or milky white plasma, supernatant layer of white color, lipemia retinalis, and eruptive xanthoma. And in surgery, we have read wherever triglycerides are increased, they put pressure on pancreas, pancreatitis present with acute abdomen, pain abdomen. Now we come to further metabolism of VLDL. So till now I have told you whatever diet we take in which triglyceride is transported in the form of chylomicron, this chylomicron is metabolized with the help of lipoprotein lipase and ApoC2 and converted to chylomicron remnant. This is taken up by with the help of ApoE. Now liver synthesize endogenous triglyceride. Yes, which comes from diet, that is called exogenous. Liver synthesized triglyceride, that is called endogenous. This endogenous triglyceride is transported in the form of VLDL. VLDL contain endogenous triglyceride and it contain ApoB100 in periphery. And when this VLDL travel via blood vessel, again it is acted upon by lipoprotein lipase. So lipoprotein lipase will act on this VLDL, and as it will travel, fatty acid will be released just like chylomicron. So in type 1 hyperlipoproteinemia, this was defective. So VLDL will not be metabolized. So in type 1 hyperlipoproteinemia, chylomicron and VLDL both are increased, but chylomicron increases more than VLDL. Point it out. Now this VLDL will travel, fatty acid will be released, and ultimately it will be converted to remnant, and that is called VLDL remnant. Another name of VLDL remnant is ideal. And ideal or VLDL remnant contain both triglyceride and cholesterol. So again, mnemonic I am making, yes, if chylomicron is increased, triglyceride increased. If VLDL is increased, it contain mainly triglyceride is increased. If chylomicron remnant is increased, means both triglyceride and cholesterol increased. If VLDL remnant are increased, both triglyceride and cholesterol increased. Clear? Now, this ideal will move further and more fatty acid will be released, and ultimately all triglyceride removed. Only and only cholesterol is left. Only cholesterol is left. When only cholesterol is left, that is bad cholesterol. This is LDL. And we saw that LDL contain only and only ApoB100. And liver is having LDL receptor. So suppose my hand is LDL receptor and this phone is ApoB100. Now this LDL having ApoB100 will go to LDL receptor. So ligand for LDL receptor is ApoB100. It will bind and it will take inside the liver by receptor mediated endocytosis. Point it out. Means this LDL is taken up by liver with the help of LDL receptor and ApoB100. If any one of this is defective, LDL will not be taken up by liver. And if LDL will not be taken up by liver, it will remain in blood. And when it will remain in blood, it will deposit this bad cholesterol in peripheral tissue, and this will be oxidized and will start atherosclerosis, coronary artery disease, cardiovascular disease. That's why we say in blood, if LDL is high, then it predisposed to coronary artery disease. What are the reason when LDL will be high? If ApoB100 is defective or LDL receptor is defective, then LDL will not be cleared from blood, and then this will cause type 2A hyperlipoproteinemia. Yes, type 2A hyperlipoproteinemia type 2A. Another name is familial hypercholesterolemia. Why? Because in type 2A hyperlipoproteinemia, defect in LDL receptor or ApoB100. So when LDL receptor or ApoB100 is defective, LDL will not be taken from the blood by liver. So LDL will increase. LDL contain bad cholesterol and it cause, yes, coronary artery disease. So lipoprotein LDL increase, which contain cholesterol, and this cause coronary artery disease, chest pain. So mnemonic, yes, chest R2. So type 2 chest pain. Acute abdomen is 1. So type 1 hyperlipoproteinemia, acute abdomen. Type 2 hyperlipoproteinemia, chest pain. And when cholesterol is increased, this cholesterol deposit in tendon to produce tendon xanthoma. I remember cholesterol as egg yolk. So mnemonic, if I deposit this egg yolk at this point, so you will say, yes, this is tendon xanthoma or tuberous xanthoma, and most common site is tendoachilles. Most common site of tendon xanthoma. So this is type 2A hyperlipoproteinemia. So I have discussed the metabolism of lipoprotein. Now you can remember the sequence. Yes, chylomicron is converted to chylomicron remnant. Then VLDL is converted to IDL, then LDL. So sequence: chylomicron remnant, VLDL remnant, LDL, HDL. So this is the sequence and size decreases. So you can see here, I also have taken in such a way that size is decreasing. Okay. Now, type 3 hyperlipoproteinemia. I told you that ApoE is responsible for the metabolism of this chylomicron remnant. Chylomicron remnant is metabolized with the help of ApoE. If it is deficient, then chylomicron remnant will not be metabolized, and chylomicron remnant contain both triglyceride and cholesterol. So in type 3 hyperlipoproteinemia, 3 looks like E. ApoE is defective. And if ApoE is defective, then remnants are increases. It may be chylomicron remnant or VLDL remnant. Both are metabolized by ApoE. Question: if ApoE is defective, remnants are increased. Remnant are having both cholesterol and triglyceride. When cholesterol is increased, tuberous xanthoma. When triglyceride increase, eruptive xanthoma. So in type 3 hyperlipoproteinemia, there is tuberoeruptive xanthoma. So tubereruptive xanthoma looks like bunch of grape appearance. Yes, bunch of grape appearance. Yes, and there is type 3 hyperlipoproteinemia. There is palmar xanthoma, increase of palm. Yes, it looks like E. I remember these crease as E. So in type 3, ApoE is defective, palmar xanthoma would be there. Type 3 hyperlipoproteinemia is also called dysbeta lipoproteinemia. Now we come to HDL. We say HDL cholesterol is good cholesterol and LDL cholesterol is bad cholesterol because LDL deposit cholesterol in peripheral tissue and predispose to coronary artery disease. While HDL take that cholesterol from periphery. Means LDL is going via blood vessel, it is depositing cholesterol. Now HDL is also coming and take this extra cholesterol and esterify it and keep it in the secure way. So HDL take cholesterol from periphery and convert it into cholesterol ester and ultimately give it to liver. Normally, I told you that transport of lipid started from liver like this and it was deposited in periphery. But HDL take cholesterol from periphery and gave to liver. So that's why it is called reverse cholesterol transport because it do it reverse direction, take cholesterol from periphery and give to liver. We found that HDL contain ApoA, ApoC2 and ApoE. Mnemonic is ACE inhibitor, AC2E. It take cholesterol from peripheral tissue and contain good cholesterol. It contain ApoA. That's why it is called lipoprotein capital A. Point it out. This lipoprotein capital A or HDL or alpha lipoprotein, three name. They are cardioprotective. Three name for the same thing. But lipoprotein small a is different and it predisposed to cardiovascular disease. This important point sometimes in capital A will be given the option or small a, so you will differentiate it. A predisposed to cardiovascular disease. And how it take cholesterol from periphery? It take cholesterol from periphery and take one acyl group from lecithin to form cholesterol ester. And name of enzyme is LCAT, lecithin cholesterol acyl transferase. A question is asked that LCAT is activated by ApoA1. So ApoA1 is activator of LCAT. This LCAT may be deficient. If LCAT is completely deficient, complete deficiency, this is called no rum gum hi gum and stage kidney disease and corneal clouding. No-rum disease, complete deficiency of LCAT. If partial deficiency of LCAT, this partial deficiency, then it is fish eye disease. In fish eye disease, only corneal clouding. Name itself tells you only eyes are involved, corneal clouding. Now, a question is asked when you see this tang. Yes, most common flavor of tang is orange color. So if you are drinking tang again and again, your tonsil would be orange color. So this is pathognomic orange color tonsil, Tangier disease. Now you will see tang is number one drink. So gene defect is ABCA1. Now A1 drink is tang. So ABCA1 defect lead to Tangier disease. Normally ABCA1 transfer cholesterol from peripheral tissue to HDL. So if ABCA1 is defective, then HDL will not be produced. So decrease HDL in Tangier disease. And this cholesterol will deposit in peripheral organ producing, yes, orange color tonsil, hepatosplenomegaly, peripheral neuropathy. This is Tangier disease. Now we discuss sphingolipidosis. Sphingolipidosis are lysosomal storage disease. We found that fatty acid, example palmitoyl coenzyme bind with sphingosine to form ceramide. Ceramide is normally metabolized in our body with the help of enzyme ceramidase. If this ceramidase is deficient, then it leads to Farber disease. Farber, Farber, Farber as barber. So barber cut hair of sir. So barber, sir ke baal, ceramidase is deficient. If a barber is cutting here, since morning to evening, he would have joint pain, just like rheumatoid arthritis. So in clinical scenario, you will find joint pain like rheumatoid arthritis. And if he is cutting, then there would be nodule due to the pressure of that scissor. So subcutaneous nodule, subcutaneous nodule. Sometime image is also given, joint pain is there, just like rheumatoid arthritis, just like juvenile arthritis, they will give hepatosplenomegaly, clinical scenario would be given, and by catching point of this subcutaneous nodule and joint pain, you will mark the answer Farber disease, in which ceramidase is deficient. Now this ceramide can bind to glucose or galactose, monosaccharide. When ceramide bind with glucose or galactose, it makes cerebroside. I am telling you this sequence because sometimes question is asked, ceramide is made up of sphingosine plus fatty acid. Cerebroside is made up of monosaccharide, glucose or galactose plus ceramide. So this cerebroside may be glucose cerebroside or galactocerebroside. If ceramide bind with glucose, then it is glucocerebroside. If ceramide bind with galactose, it is galactocerebroside. We found that glucocerebroside is found in extraneural tissue, and galactocerebroside is found in nervous system. We found that this glucocerebroside is normally metabolized by glucocerebrosidase. Another name is beta glucosidase. So glucocerebrosidase or beta glucosidase, if this is deficient, then it lead to Gaucher disease. So mnemonic is U. Glucocerebroside is metabolized by glucocerebrosidase by beta glucosidase. If beta glucosidase or glucocerebrosidase is deficient, that lead to Gaucher disease. U. If galactocerebroside is there, it is metabolized by galactocerebrosidase, or another name is beta galactosidase. If this enzyme is deficient, then it lead to Krabbe's disease. Now, we found that in Gaucher disease, this glucocerebroside will accumulate in extraneural tissue. Means nervous system will not be affected. So no mental retardation, no neurological symptom, and retina you can consider as part of nervous system. Neurons are there. So retina, cherry red spots are not there. So I can say that in this negative point, no neurological symptom means no mental retardation. No mental retardation is also called intellectual disability. Cherry red spot absent. Sometime I remember G for Gaucher disease, G for genius bacha, genius patient. So no mental retardation. Although they are not genius, but you will remember that there is no mental retardation. In Krabbe's disease, there would be nervous tissue affected. So neurological symptom would be there. Neurological symptoms would be there. Means cherry red spot may be present. So In Gaucher and Krabbe's disease, you can differentiate like this. In Gaucher disease, it is accumulated in extraneurial tissue. It will accumulate in liver, hepatomegaly, spleen, hepatosplenomegaly. So hepatosplenomegaly would be present. But in Krabbe's disease, hepatosplenomegaly would be absent. This is important difference. In Gaucher disease, you will find bone pain. These will deposit yes, glucocerebroside will deposit in bone. Bone pain would be there. When bone pain would be there, you will say ouch, ouch, Gaucher, ouch, ouch, Gaucher, bone pain. And when you will say ouch, ouch, I will give you tissue paper and you will do like this and throw it. Crumpled tissue paper appearance. Crumpled tissue paper appearance. Most of time questions are solved by this image only. Crumpled tissue paper appearance, Gaucher disease. And in this, bone pain is there and there would be Euler-Meyer-Flass deformity in bone. Euler-Meyer-Flass deformity in bone. Yes, in this pancytopenia, thrombocytopenia, bleeding manifestation may be there. Although questions are solved mostly by this crumpled tissue paper appearance, ouch, ouch, yes, tissue paper crumpled. In Krabbe's disease, there are globoid cells. These are globoid cells in Krabbe's disease. Now, we found that ceramide can bind with phosphate. Important point. Ceramide bind with phosphate plus choline. So, phosphate, choline plus ceramide make sphingomyelin. This sphingomyelin is normally metabolized by enzyme sphingomyelinase. If sphingomyelinase is deficient, then it leads to Niemann-Pick disease. Mnemonic for this is neem soap. Yes, if you take the neem soap of Baba Ramdev, which is very strong, when you take bath, you will find bubbly appearance, foamy appearance. If you take bath after such a long time during winters, bubble would not be so clear, so nice. This is bubbly appearance, foamy appearance. And Baba Ramdev claimed that my neem soap is so strong, if you wash zebra will become donkey, means all the stripes will be washed. I am not concerned with this claim, but just a hypothetical story so that you will remember that zebra bodies and foamy appearance, bubbly appearance is found in Niemann-Pick disease. Mnemonic is neem soap. Now we come to other lysosomal storage disease, sphingolipidosis. Next is Tay-Sachs disease. In this, hexosaminidase A is deficient. You can easily remember by mnemonic Sachs 6. 6 hexose means 6. So hexosaminidase A is deficient. We found that in Tay-Sachs disease there is tiny organ. Tiny organ means no hepatosplenomegaly. No hepatosplenomegaly. And in Tay-Sachs disease there is cherry red spot. So I have discussed this Tay-Sachs disease here, and at the same time Niemann-Pick disease I am taking again. In Niemann-Pick disease there would be cherry red spot, just like Tay-Sachs disease. In Tay-Sachs disease, there are neurological symptoms. Neurological symptoms. In Niemann-Pick disease, again there is neurological symptoms. Neurological symptoms. So how you will differentiate? Sometime clinical question is asked and they want you to differentiate. Yes, Tay-Sachs, tiny organ, no hepatosplenomegaly. Niemann-Pick, big. So big organ means hepatosplenomegaly present. Hepatosplenomegaly present, although multiple symptoms may differ, but when they give clinical scenario, they try to confuse you between Tay-Sachs disease, mnemonic is tiny organs, Niemann-Pick disease, Niemann-Pick big. So hepatosplenomegaly present, both are having cherry red spot and neurological symptoms. Neem soap mnemonic. Now, metachromatic leukodystrophy, you can easily remember mnemonic. Aerial surf. Aryl sulfatase A. Yes, in aryl sulf you can find multiple color granules, metachromatic multiple color granules. Aryl sulfatase A is deficient. Now Fabry's disease, I will remember Fabry's as fabrics. Fabrics or fabrics. So X means Fabry's disease is X-linked recessive. X-linked recessive. All other sphingolipidosis I have discussed till now and will discuss, all are autosomal recessive. But this Fabry's disease is X-linked recessive. So mnemonic is Fabrics X-link. And which enzyme is deficient? Alpha galactosidase is deficient. And if I want to make mnemonic, I can cut this alpha and it will look like X. Now it is looking like X. So Fabrics alpha galactosidase is deficient. Fabric, it's a good fabric, means even in summer you will not have hydrosis, means sweating will not be there, means hypohidrosis with a good fabric. And in Fabrics disease or Fabry's disease, there is angiokeratoma, that is benign cutaneous lesion of capillaries, red to blue color, characterized by hyperkeratosis. This is angiokeratoma. So this is blue color or red color fabrics. Now in Fabry's disease, there is Maltese cross appearance. Yes, cross. Wherever you find cross, Fabrics cross, X-linked recessive cross. Yes, alpha, yes, it is also looking like cross. So this is Fabry's disease or Fabrics disease, alpha galactosidase deficiency. Now we discuss GM2 ganglioside. GM2 ganglioside is converted to GM3 by hexosaminidase A. And hexosaminidase A and B. If hexosaminidase A is deficient, this is Tay-Sachs disease. I have already discussed. Mnemonic for this is S46 and hexose means 6. Tay-Sachs T42 means in Tay-Sachs disease, GM2 ganglioside will not be metabolized and there would be GM2 gangliosidosis. GM2 gangliosidosis. In Tay-Sachs disease, another name is GM2 gangliosidosis. Sandhoff disease, Sandhoff. Hexosaminidase A and B both are deficient and sand. So Sandhoff will tell you itself that and A and B both are deficient. So if this step is not occurring, GM2 will accumulate. So this is GM2 gangliosidosis. So example of GM2 gangliosidosis are Tay-Sachs disease and Sandhoff disease. Now we are discussing Wolman disease. This is not sphingolipidosis. Point it out. That's why I am putting it in a box. This is not sphingolipidosis. Yes, enzyme defect is acid lipase. This is lysosomal storage disease, but not sphingolipidosis. In this, there would be adrenal calcification, bilateral calcification of adrenals. This is catching point. Sometimes in question, watery diarrhea, W4 Wolman, W4 watery diarrhea. So this is about Wolman disease. Now, many times clinical scenario you will get and you will catch the answer by single point. And this is important. All sphingolipidosis have mental retardation, intellectual disability, except Fabry's and Goucher. How you will remember? Fabry's fabulous performance means no mental retardation. Goucher, genius, means no mental retardation. Although they are not genius, but Yes, you may remember no mental retardation in Fabry's or genius means CNS is not being affected. And I told you that retina is also considered as part of CNS for question purpose. This you may remember like this. So no cherry red spot in Fabry's and Gaucher. No cherry red spot. All sphingolipidosis have cherry red spots except Fabry's and Gaucher's. Now, all sphingolipidosis are autosomal recessive except Fabric's X-linked recessive. All sphingolipidosis have hepatosplenomegaly except Tay-Sachs disease and Krabbe's disease. I told you T for tiny organs. And Krabbe's disease, I told you Krabbe's disease that galactocerebroside accumulate in nervous tissue, no hepatosplenomegaly, but you will forget, so make the mnemonic tash ka patta. Tash ka patta means thin, just like tash ka patta. Sorry to be in Hindi, that tash ka patta is very thin. So Tay-Sachs and Krabbe's disease, or if you want to remember kekda, पतला सा होता है, सूखा सा, no hepatosplenomegaly, Krabbe's disease. Okay, Krabbe. Now, lipotropic factors. These factors help in mobilization of triglyceride from liver. If deficiency of lipotropic factor, that will lead to fatty liver. Example of lipotropic factor question has been asked: choline, B12, folic acid, methionine, amino acid. These are common lipotropic factor. Now I am going to describe very important concept that two opposite pathways are regulated in such a way when one is activated, other should be kept in inhibited state. Yes, two opposite pathways are regulated in such a way when one is activated, other should be kept in inhibited state. So in fat state, you know, hormone of fat state is insulin. Hormone of fasting or starvation is glucagon. Now we know that glucose is converted to glycogen, that is glycogen synthesis. Glycogen is broken down to glucose, this is glycogenolysis. These are two opposite pathways. Glucose is converted to pyruvate, that is glycolysis. When two pyruvate join, they form glucose, that is gluconeogenesis. These are again two opposite pathways. Acetyl coenzyme join to make fatty acid synthesis. And whenever we do beta oxidation of fatty acid, then fatty acid converted to acetyl coenzyme, beta oxidation of fatty acid. So fatty acid synthesis and beta oxidation of fatty acid are opposite pathway. Glycolysis, gluconeogenesis are opposite pathway. Glycogen synthesis, glycogenolysis are opposite pathway. These must be regulated in such a way when one is activated, other should be kept in inhibited state. So I take insulin. Insulin activate glycogen synthesis. So insulin must inhibit, yes, glycogenolysis. Insulin activate glycolysis. So insulin must inhibit gluconeogenesis. So insulin activate fatty acid synthesis. So insulin must inhibit beta oxidation of fatty acid. Two opposite pathways are regulated in such a way when one is activated, another is kept in inhibited state. Now you can easily remember all enzymes of these pathway, means glycogen synthesis, glycolysis and fatty acid synthesis, they are activated by insulin, and enzyme of glycogenolysis, gluconeogenesis and beta oxidation of fatty acid are inhibited by insulin. Most of time questions are surrounded by these three pathways, opposite pathways. Concept: glucagon, yes, do exactly opposite. Glucagon activate glycogenolysis, gluconeogenesis, beta oxidation of fatty acid. We know that insulin insult phosphate, insulin do incision, remove phosphate. So we know that enzyme which are activated by insulin are active in dephosphorylated state. Dephosphorylated state. So now I can ask you that glycogen synthase is active in dephosphorylated state. Phosphoroctokinase of glycolysis active in dephosphorylated state. Acetyl coenzyme carboxylase of fatty acid synthesis is active in dephosphorylated state, and exactly opposite these rate limiting enzyme of these pathway, yes, active in phosphorylated state. If you remember, I told you glycogenolysis, glycogen phosphorylase, Thanos. Yes, phosphate is joined, became powerful, means glycogen phosphorylase is active in a phosphorylated state. So this is very important. Most of the question about phosphorylation, dephosphorylation, and regulation by insulin and glucagon are asked around these three opposite pathway. These are reciprocal pathway which are regulated in such a way when one is activated, another should be kept in inhibited state. Now we discuss amino acid. Amino acid name itself tells you that there is amino group and acidic group, one H group, and there is side chain, that is R. So each and every amino acid is having common structure, that they are having this amino group, acidic group, H, and side chain is different. So you can classify amino acid on the basis of side chain because this portion is common to each and every amino acid. When we saw the structure of this amino acid, we found that this carbon, all four valencies are occupied by different group. And you know, if carbon, all four valencies are occupied by different group, that is called asymmetric carbon atom. So amino acids are having asymmetric carbon atom, and any compound having asymmetric carbon atom show optical and stereoisomerism. So amino acids show optical and stereoisomerism. Now we classify amino acid on the basis of their side chain. First group of amino acid is aliphatic amino acid. Aliphatic mnemonic is aliga-live. Ali for aliphatic, G for glycine, A for alanine, live, L for leucine, I for isoleucine, V for valine. First is glycine. So glycine, if you see the structure of glycine, in side chain there is H. There is H. If I ask you, smallest R group may be, you will say, sir, smallest atom is H. So you can say glycine is having smallest side chain. So this is smallest amino acid. This is simplest amino acid. And if you see this carbon, you will say this carbon is occupied by 2H. Means two valencies are occupied by same group. It is a symmetric carbon. So I can say glycine has no asymmetric carbon atom. So it will not show optical or stereoisomerism. So till now I have told you glycine is simplest amino acid, smallest amino acid, no asymmetric carbon atom. So it will not show any optical or stereoisomerism. So first amino acid I discussed is glycine. This is simplest amino acid and side chain is only H. Second amino acid, alanine, A, first alphabet, one carbon. So if side chain is having only one carbon, then this is alanine. And if I count the number of carbon in alanine, I will find that 1, 2, 3 carbon. So alanine is having only 3 carbon, yes, and any 3 carbon compound may be good substrate for gluconeogenesis. You take 2 molecules of 3 carbon, join 6 carbon glucose. So alanine can be converted to glucose very easily. That's why alanine is most important glucogenic amino acid question. So till now I have told you this glycine and alanine, these are very small. Yes, can you synthesize? Yes, you can easily synthesize. Joining of hydrogen, joining of methyl is very easy. So you can synthesize glycine and alanine in your body, and anything which can be synthesized in our body, that is non-essential. So this is non-essential. So these two are non-essential. Now questions are asked on glycine metabolic function. First question, that glycine is used in the synthesis of heme. Heme is made up of glycine and succinyl coenzyme. First step of heme synthesis, glycine bind with succinyl coenzyme to form delta amino levulinic acid. So glycine take part in heme synthesis. Glycine contribute carbon number 4, 5 and nitrogen 7 in purine ring. So glycine is utilized completely, पूरा का पूरा utilize हो जाता है purine में glycine. So used in purine. It also take part in synthesis of glutathione. You can easily make mnemonic gluta means glutamate. Thio means cysteine. Cysteine is having SH group, and you know SH group means thio group. So cysteine. And then one. I told you the first amino acid we discussed is glycine. So glycine is first amino acid we are discussing. So you can say gluta for glutamate, thio for cysteine, 1 for glycine. So glutathione is a tripeptide in which one amino acid is glycine. Glycine also take part in collagen synthesis. In collagen, every third amino acid is glycine. Collagen is glycine XY, glycine XY. Every third amino acid is glycine. Now, creatinine. This is recently asked question. Game. We will create a game. Game bajana nahi, game create karna hai. Yes, that is G for glycine. G for glycine. A for arginine, Me for methionine. So creatinine is made up of glycine, arginine and methionine. These are the function of glycine where glycine is used in synthesis. We found that glycine also take part in conjugation reaction. Bile acid, cholic acid bind with glycine to form glycocholic acid. So glycine take part in conjugation of bile acid. First question. It is also used in phase 2 reaction of xenobiotic metabolism. We found that in our body, benzoic acid bind with glycine to form hippurate. Question is asked that in our body, benzoic acid is conjugated with glycine and the product is hippurate, and this hippurate is excreted in urine. So hippurate or hippuric acid is excreted in urine. We found that other than these conjugation reaction, very important reaction is glyoxylate is converted to glycine by an enzyme alanine glyoxylate aminotransferase. Means this enzyme help in the transfer of amino group to glyoxylate. And when you transfer amino group to glyoxylate, then it is converted to glycine. And cofactor for aminotransferase, yes, transaminase, you know, transamination cofactor is B6. So in this reaction, again, cofactor is B6. If this enzyme is deficient, then glyoxylate will increase because this reaction will not occur. Glyoxylate will be converted to oxalate. This oxalate increases and cause kidney stone, and this is called primary hyperoxaluria. So this enzyme deficiency lead to primary hyperoxaluria. We found that if B6 is deficient, again this reaction will not occur because cofactor for this reaction is B6, pyridoxal phosphate. So if B6 is deficient, again oxalate will increase, and this is called, yes, B6 secondary hyperoxaluria. Other cause of secondary hyperoxaluria is vitamin C excess, ethylene glycol poisoning. All these are questions, recently asked question. So primary hyperoxaluria, this enzyme is deficient. Secondary hyperoxaluria, B6 deficiency, or vitamin C excess, ethylene glycol poisoning. So till now we have discussed glycine and alanine. Now we come to live. Yes, live. Leucine, isoleucine and valine. If you see the structure, don't remember the structure, just have an idea. If I say this is valine, in this valine, this is branching. This leucine, L, this is branching. Isoleucine, this is branching. So all these three, These are branch chain amino acid live. And you know that branching is not a simple process. You can't synthesize branch chain amino acid in your body. So these three branch chain amino acid are essential. And the mnemonic is these three are essential to live. Branch chain amino acid are essential to live. So again, I am repeating valine V. If you write inverted V, that is valine. Leucine, this is L, branching. This is isoleucine, this is again branching. So these are branch chain amino acid, cannot be synthesized, so they are essential. Mnemonic is essential to live. Live, L for leucine, I for isoleucine, V for valine. And we found that out of these 5 aliphatic amino acid, all are considered non-polar. Non-polar except, yes, all these 5 aliphatic are non-polar except this glycine. Glycine, according to Harper, this is polar. And if polar is not given the option, you can consider it as non-polar. So Harper says it is polar. So all aliphatic amino acid 5, I told you, Ga live, these are non-polar except glycine, which is polar. Now, branch chain amino acid metabolism. First amino acid is leucine. Again, I will say the same mnemonic live. Live. Yes, leucine is metabolized. L for leucine. Leucine is metabolized to I for iso, V for valeric acid. So leucine is metabolized to isovaleric acid. This isovaleric acid is further metabolized by dehydrogenase. Isovaleric acid dehydrogenase. If isovaleric dehydrogenase is deficient, then this isovaleric acid will be accumulated. So isovaleric acid urea. Isovaleric acid urea. And in isovaleric acid urea, question is asked, there is a sweaty fit odor. Yes, sweaty fit odor. How you will remember? Yes, valeric acid V. V looks like 5. V looks like 5. So fit is having how many toes? 5 toes. So sweaty fit odor isovaleric. Question is asked that isovaleric acid urea is due to defect in the metabolism of leucine. Yes, answer is leucine. Don't get confused by name, because when you will read the name isovaleric, you will think of isoleucine. No, it is not defect in the metabolism of isoleucine. When you will read valeric, you will think of valine. No, it is not due to defect of valine metabolism. It is due to defect of leucine metabolism. That's why I told you this mnemonic live, so essential to live, and live, L for leucine, I for iso, V for valeric acid is produced. We found that these 3 branch chain amino acid are metabolized by enzyme branch chain alpha keto acid dehydrogenase. This dehydrogenase do oxidative decarboxylation. And you know, wherever oxidative decarboxylation of alpha keto acid is there, O4 oxidative, O4 1. Vitamin B1 is cofactor for this branch chain alpha keto acid dehydrogenase. And this is multi-enzyme complex. In these 3 enzymatic activities are there, E1, E2, E3. So this branch chain alpha keto acid dehydrogenase, in this E1 is decarboxylase. Point it out. Now, if I say that this branch chain alpha keto acid dehydrogenase is deficient, that lead to maple syrup urine disease. Maple you will remember as apple. Apple tree is having branch. Apple tree is having branch. So maple syrup urine disease, branch chain alpha keto acid dehydrogenase deficient. Sometimes in question, you will not find this dehydrogenase. You will find that the enzyme deficient is branch chain alpha keto acid decarboxylase. That is also true, because you know that one enzyme is E1 is decarboxylase. So don't get confused. In this, maple syrup Smell of urine would be just like maple syrup or burnt sugar. Smell of urine would be there. We found that in maple syrup urine disease, these branch chain amino acid will not be metabolized. When they will not be metabolized, they will increase in blood, they will increase in urine. So question is asked that which amino acid increase in blood or urine in maple syrup urine disease? Mnemonic again, live, leucine, isoleucine and valine. And what is the test for maple syrup urine disease? That is DNPH, dinitrophenyl hydrogen test. And in this there is yellow precipitate. Yes, how you will remember? PH, pila hai, pila hai. So yellow, pila, yellow is pila, yellow precipitate. And how you will remember that maple as apple? If you cut apple, after some time it becomes brown or yellowish. So maple syrup urine disease, maple apple tree branch, and after cutting it become pila. So pH, DNPH test and yellow precipitate is produced. Till now we have discussed 5 aliphatic amino acid. Now next group is amino acid having OH group in their side chain. Means OH containing amino acid. Mnemonic is OH tri-3-sari. OH tri-3-sari. O means OH containing, tri means tyrosine, 3 means threonine, sari for serine. These are having OH group, and you know wherever there is OH group, compound is polar. So all these 3 amino acid are polar. But according to Harper, tyrosine is non-polar. So if question is asked, then you will prefer to mark tyrosine as non-polar. If non-polar is not given, then you can mark it polar. We found that anywhere OH group is there, this OH group has tendency to attach with phosphate. So all these 3 amino acid have tendency to attach with phosphate. Out of these 3, serine is most common amino acid which attach with phosphate. Question is asked that which of the following amino acid is phosphorylated easily? The answer would be serine. So these are OH containing amino acid, or OH in their side chain. Mnemonic is O tri-3-sari. And question is asked that out of these 3, one is essential, biggest one. So I am not aware about the structure, but I am aware about the name. If you remember the name spelling, you can see that threonine is having 9 letters, tyrosine is having 8 letters, serine is having only 6. So longest is threonine. Longest would be difficult to be synthesized. So threonine cannot be synthesized in our body. So it is essential, while tyrosine and serine are non-essential. Now, amino acid. Proline is an amino acid. This is not amino acid. In this NH is there, and this is the structure, little bit different structure. This is amino acid and it is also non-polar. Now next group is sulfur containing amino acid, and mnemonic for this is sister is slow in math. Cis for cysteine, slow as for sulfur containing, math for methionine. So sulfur containing amino acid are cysteine and methionine, and you can easily differentiate that methionine is large, yes, and cysteine is small. So which is large, difficult to synthesize, which cannot be synthesized in our body, that is essential. So methionine is essential and cysteine is non-essential, because cysteine is synthesized in our body. If you see the structure of cysteine, you will find that this portion is common to each and every amino acid. Only side chain, this CH2SH is different. So cysteine is having CH2SH. But methionine is having large side chain. That is, yes, CH2, CH2S, CH3. This is methionine. So I told you sulfur containing amino acid, and I gave you example of cysteine and methionine. But I have not mentioned about homocysteine. Although homocysteine is also having sulfur, but I have separated it. Because homocysteine don't take part in protein synthesis. Cysteine and methionine take part in protein synthesis. Homocysteine not take part in protein synthesis. In fact, homocysteine, if increases in blood, it produces atherosclerosis, predisposed to atherosclerosis, cardiovascular disease, coronary artery disease, atherosclerosis. When we saw the structure of homocysteine and methionine, we found that this portion is common to both homocysteine and methionine. The only difference was methyl group. So I can say that if I remove this methyl group from methionine, it will be converted to homocysteine. Yes or no? Yes. Methionine, if I remove methyl group, it will be converted to homocysteine. I don't say remember the structure, just have an idea. Or if I join methyl group to homocysteine, then it will be converted to methionine. So homocysteine to methionine or methionine to homocysteine can be easily converted. The only difference is methyl group. So we found that this methionine, this sulfur is naughty. The sulfur is naughty. It want to bind to other compound also. Yes. This sulfur interact with adenosine. And when sulfur interact with adenosine, you will say this is S-adenosyl methionine. Means that methionine which is having adenosyl at sulfur. So S-adenosyl methionine, SAM. So SAM is S-adenosyl methionine. So when this adenosine will interact with the sulfur, suppose this is a bench, 3 students already seated and 4th student came and anyhow entered between them, and now he is pushing like that. Methyl is out. So this SAM, this adenosyl will interact with it and will dissociate this methyl. So SAM is a very important methyl group donor. Question is asked, SAM is universal methyl group donor. Question. Now, we found that in our body, methionine is metabolized. When methionine is metabolized, this methionine methyl group is removed. When methyl group is removed from a methionine, it is converted to homocysteine. So methyl group is removed, it is converted to homocysteine. This homocysteine react with serine. If you don't remember, it's okay. Just have an idea. Methionine is going to homocysteine. Now it interact with serine, okay, to form cystathionine. And the name of enzyme is cystathionine beta synthase. Cystathionine beta synthase. And the cofactor for this cystathionine beta synthase is vitamin B6. Cofactor is vitamin B6. This cystathionine is further dissociated into homoserine and cysteine. So this is normal pathway of methionine metabolism. We found that methionine is converted to homocysteine. This homocysteine is converted to cystathionine by cystathionine beta synthase, and cofactor for this cystathionine beta synthase is B6. This cystathionine is further converted to cysteine. So normally cysteine is synthesized in our body from methionine, and anything which is synthesized in our body is non-essential. While methionine is essential, I have already told you. But in case of classical homocystinuria, what is classical homocystinuria? If cystathionine beta synthase is not working, then this step would not occur. When this step would not occur, this homocysteine will accumulate. When this step is not occurring, then homocysteine will accumulate, and this is called homocystinemia, homocystinuria. So this is classical homocystinuria in which cystathionine beta synthase is deficient. So this is classical homocystinuria, biochemical defect is increase homocysteine in blood. So in classical homocystinuria, this enzyme is not working. So homocysteine will increase in blood. When homocysteine will increase in blood, it will come in urine. So homocystinuria, increase homocysteine. Yes, homocysteine in urine. And cysteine will not be synthesized. So decrease cysteine synthesis would be there. So in case of classical homocystinuria, I can say that cysteine is not synthesized. When it is not synthesized, it must be supplied from diet. So it becomes essential. So question is asked that cysteine becomes essential amino acid in classical homocystinuria. Classical homocystinuria. This is important point. Now, we found that homocystinuria may be present, homocysteine may be increased in B6 deficiency. If B6 is deficient, then this step would not occur, this enzyme will not work. Again, homocystinuria would be there. But in B6 deficiency, you can easily differentiate if B6 is deficient. First step of heme synthesis, glycine bind with succinyl coenzyme A to form delta aminolevulinic acid. The rate limiting step of heme synthesis require B6 as cofactor. If B6 is deficient, heme synthesis will not occur. This will lead to sideroblastic anemia. So sometime clinical scenario they ask and they give sideroblastic anemia is also there, homocystinuria is also there. So you will suspect that there may be B6 deficiency. There may be B6 deficiency. So I told you that in classical homocystinuria, there is decreased synthesis of cysteine. So in treatment, you will give cysteine. So one question that in this patient of classical homocystinuria, treatment will include cysteine supplement. You will restrict diet in methionine. You can't stop methionine, but restriction of methionine, point it out. If you will stop, that is not acceptable because methionine is essential amino acid. You can't stop, but you will restrict the diet. Yes, methionine restriction would be there. We will give high dose of B6. Why high dose of B6? Because B6 is cofactor for cystathionine beta synthase. So I have told you that this classical homocystinuria, this enzyme is deficient and homocysteine will increase. Homocysteine predisposed to coronary artery disease, atherosclerosis, cardiovascular disease. So what we will do, we will restrict the methionine diet. First point, treatment, we will give cysteine in the treatment because cysteine is not synthesized. Third point, we will give B6 supplementation to support this cystathionine beta synthase. So what are the clinical features? There would be skeletal deformity, tall, arachnodactyly, genuverum, genuvalgum, pes cavus planus, and in this there is dislocation of lens, that is downward and medially. How you remember homocystinuria, urine goes downward, yes, and we try to put it in port medially, yes, downward and medially. And there is mental retardation. We found that if tall stature, arachnodactyly is there, dislocation of lens is there, immediately you may think of differential diagnosis, Marfan syndrome. But in Marfan syndrome, one point, differentiating point is no mental retardation. Mnemonic is marvelous performance. Yes, no mental retardation. And superiotemporal dislocation of lens means dislocation of lens upward and outward. Marfan, fan of split AC. Yes, outer unit, upward and outward. So Marfan syndrome, upward and outward. So by this, you can differentiate between classical homocystinuria and Marfan syndrome. Now we come to one metabolic pathway, that is homocysteine is converted to methionine by enzyme homocysteine methyl transferase. I told you the only difference between homocysteine and methionine is methyl. If I join methyl group to homocysteine, it will be converted to methionine. So we found that homocysteine methyl transferase will transfer methyl group to homocysteine, and homocysteine will be converted to methionine in our body, and this require folic acid and B12 as cofactor, or you can say folic acid is methyl group donor in this homocysteine methyl transferase, and another name for this same enzyme is methionine synthase. Methionine synthase. If folic acid is deficient or B12 is deficient, this homocysteine will not be converted to methionine. Homocysteine will be increased, and this is called non-classical homocystinuria. Non-classical homocystinuria. So how you will differentiate that this non-classical homocystinuria is due to B12 deficiency or folic acid deficiency? In B12 or folic acid deficiency, both of the cases, that homocysteine will increase. Homocysteine will increase. We all know B12 deficiency lead to megaloblastic anemia, folic acid deficiency lead to megaloblastic anemia. So how you will differentiate between these two? Yes, we found there is a step. Methyl malonyl coenzyme A. Methyl malonyl, methyl 1 carbon, malonyl 3 carbon join to form succinyl coenzyme A 4 carbon compound. So this methyl malonyl coenzyme A is converted to succinyl coenzyme A by enzyme mutase, and the cofactor is B12. So if a patient is having B12 deficiency, then this step will not occur and methyl malonyl will increase. So if a clinical scenario is given and they give homocystinuria is there, megaloblastic anemia is there, and methyl malonyl coenzyme A is increased, means this is due to B12 deficiency. In folic acid deficiency, methyl malonyl coenzyme A would be normal. Now, next question, that is cystinuria. This is frequently asked question. They will give you image that this hexagonal crystals are there, kidney stones are there, hexagonal. Hexagonal, yes, hexa, 6, cis as 6. So cystinuria, there would be hexagonal crystal. First question mnemonic. We found that two cysteine join to make cystine. So in cystinuria or cystinuria, pronunciation is two types. Yes, you may say it cystinuria or cystinuria. In cystinuria, there is cystine, or better to say cystine in urine, ornithine, lysine, arginine. There is defect in the absorption of cola, C4 cystine. That is not cysteine. This is not monomer. This is dimer. Yes. So dimer is coming in urine. Ornithine is lysine, arginine, cola. You will remember this mnemonic, and this is cystinuria. Now we come to aromatic amino acid, phenylalanine, tyrosine, and tryptophan. First, we start with phenylalanine. Phenylalanine, we know the structure of alanine. Alanine is, this is alanine. And if I join benzene ring to alanine, that is a phenylalanine. So phenylalanine is having this benzene ring, which is a large ring, cannot be synthesized in our body. So phenylalanine cannot be synthesized in our body. So it is essential amino acid. We found that normally in our body, phenylalanine is converted to tyrosine by an enzyme phenylalanine hydroxylase. Hydroxylase will join hydroxyl group. So I can say phenylalanine is converted to tyrosine by enzyme phenylalanine hydroxylase, cis OH group. So you can differentiate that tyrosine and phenylalanine. The only difference is this OH group, and this OH group is attached by phenylalanine hydroxylase normally in our body. So normally in our body, this phenylalanine is converted to tyrosine. So tyrosine is synthesized in our body, and any amino acid which is synthesized in our body, that is non-essential. So tyrosine is a non-essential amino acid. We found that this phenylalanine is converted to tyrosine. In this reaction, tetrahydrobioctane is converted to dihydrobioctane. So when this reaction is occurring, then tetrahydrobioctane is converted to dihydrobioctane. This dihydrobioctane must be converted back to tetrahydrobioctane, and the name of enzyme for this reaction is dihydrobioctane reductase. The name of enzyme is dihydrobioctane reductase. If phenylalanine hydroxylase is deficient, this is called classical phenylketonuria. Classical phenylketonuria. Phenylalanine hydroxylase is deficient. In few patients of phenylketonuria, we found that phenylalanine hydroxylase is normal, but there is deficiency of dihydrobioctane reductase. If this enzyme is deficient, this dihydrobioctane will not be converted back to tetrahydrobioctane, so this reaction will not continue. Again, phenylketonuria. So this lead to non-classical phenylketonuria. Recently asked question in our NEET PG 24. So phenylketonuria, phenylalanine will not be metabolized to tyrosine, means tyrosine will not be able to be synthesized in our body, and now it becomes essential. So normally tyrosine is non-essential, but in phenylketonuria, tyrosine is not synthesized. So question is asked, tyrosine becomes essential amino acid in phenylketonuria because now you can't synthesize tyrosine in your body, must be supplied in diet. When phenylalanine will not be metabolized, it will be converted to phenyl pyruvate. Yes, you know, alanine. Yes, this is not related to the topic, but you have idea that whenever alanine transamination occur, means whenever you remove amino group, there is formation of keto group. So if alanine amino group is removed, it becomes pyruvate. So when phenylalanine is increased, this phenylalanine will be converted to phenyl pyruvate. And you know, pyruvate can be converted to lactate. Pyruvate can be converted to acetate. We have read in carbohydrate. So we found that this phenylalanine will accumulate. This phenylalanine will be converted to phenyl pyruvate, phenyl lactate, and phenyl acetate. So question is asked in phenylketonuria, what are the metabolite of phenylalanine increased? These three are increased. How many? 3. And question is asked that phenylketonuria patient have mousy odor or musty odor of urine. And this mousy odor is due to which component? Yes, this is due to phenyl acetate. Point it out. Phenyl acetate contribute to this musty odor. I told you these 3 metabolite. Now I will make mnemonic. 3 metabolite, 3. Guthrie's test. Guthrie's test. 3. Yes. So for phenylketonuria, we check Guthrie's test. We do ferric chloride test. Ferric. Yes. 3. Iron. So ferric chloride test and Guthrie's test for phenylketonuria. But the gold standard for phenylketonuria is tandem mass spectrometry. We found that this phenylalanine will accumulate. This phenylalanine will cause mental retardation. Child was normal at birth, but as this child will grow, child will develop mental retardation. Normal at birth, but will develop mental retardation due to increased phenylalanine. Sometimes patient would be having so severe vomiting, not improved by any way, and this will mimic pyloric stenosis. So severe vomiting, differential diagnosis is pyloric stenosis. So we have discussed this phenylalanine and tyrosine. Normally in our body, phenylalanine is converted to tyrosine, and if this conversion is defective, that is called phenylketonuria. And in these three compounds we have discussed. To check them, Guthrie's test and ferric chloride test we know, and gold standard tandem mass spectrometry. Now we discuss metabolism of tyrosine. Tyrosine is normally converted to thyroid hormone. Question is asked, precursor of thyroid hormone is tyrosine. Tyrosine is normally converted to melanin black pigment. You know, tyrosine tire. If you burn a tire, you will find a black pigment, just like you have played Holi. Yes, black pigment. So tyrosine is converted to melanin by enzyme tyrosinase. If you burn, burning means oxidation. So tyrosinase is an oxidase. Tyrosine is classified as oxidase. And when you burn tire, you will find that copper wires are seen in tire, burning tire. If you have visualized that copper, so or you can make mnemonic that wherever oxidase are there, most of time copper is cofactor. So cofactor for this tyrosinase is copper. And if tyrosinase is deficient, then it is called albinism. Albinism. In albinism, melanin will not be synthesized. When melanin will not be synthesized, there would be white skin, white hair, blue sclera, photophobia, blue eye, hypnotized theory kar di hai mainu. So blue sclera would be there. Yes, photophobia, lacrimation, these are symptoms of albinism. Why? Because tyrosine is not converted to melanin black pigment. But I told you, in phenylketonuria, tyrosine is not synthesized because this phenylalanine hydroxylase is deficient. So in phenylketonuria, again, due to decreased tyrosine, there would be albinism symptoms. So sometime clinical scenario they will try to confuse you by starting the question with symptoms of albinism. They will say that a patient is having white hair, white skin. Immediately you will start thinking about albinism, but they will give mousy odor of urine, musty odor, phenylalanine, phenylpyruvate, phenylactate, phenylacetate is increased. Yes, this is phenylketonuria. In this mental retardation would be there and severe vomiting may be there. So this is phenylketonuria in which, yes, albinism type symptoms would be there, but not so severe. Why not so severe? Because you take some amount of tyrosine from diet. That's why not severe. In albinism, in spite of having tyrosine, you can't convert tyrosine to melanin. So I have discussed the metabolism of tyrosine till now. I told you precursor of thyroid hormone, it forms melanin, and if tyrosine is deficient, it is albinism. Albinism symptoms are also seen in phenylketonuria because in phenylketonuria, tyrosine is not synthesized. Tyrosine become essential amino acid in phenylketonuria. We found that tyrosine is metabolized to dopamine, norepinephrine, and epinephrine. Catecholamines. Questions are asked that precursor for catecholamine is tyrosine, precursor for thyroid hormone is tyrosine, precursor for melanin is tyrosine. So tyrosine is very important. So we found that these catecholamines, norepinephrine and epinephrine, in this the difference is of only methyl group. Means if I add methyl group to norepinephrine, then it will be converted to epinephrine. And from where you will take this methyl group? Yes, Sam, the bad boy of the Sham movie. Sam's S-adenosyl methionine, most important universal methyl group donor. Sam gave this methyl group. Question has been asked, norepinephrine to epinephrine. We found that epinephrine is converted to metanephrine. Simple mnemonic. Yes, nephrine here, nephrine here. So epinephrine, metanephrine. Norepinephrine, normetanephrine. This Metanephrine nor metaepinephrine is converted to vanillyl mandelic acid. And we found that in pheochromocytoma, this vanillyl mandelic acid VMA is increased because more and more catecholamine synthesis occur, and that's why there is increased VMA. VMA spot test is done for pheochromocytoma. Recently asked question. So we have discussed metabolism of tyrosine, metabolism of phenylalanine. We have discussed phenylketonuria, their symptom. We have discussed albinism, their symptoms. We have discussed this catecholamine and thyroid hormone synthesis. Now one more pathway of tyrosine metabolism. In this, every time question is asked that tyrosine is converted to para-hydroxyphenyl pyruvate. If I don't remember this, okay. Simply remember, tyrosine is metabolized by tyrosine transaminase. Name itself tells you TT, 2 times T. So tyrosinemia type 2. So question is asked that in tyrosinemia type 2, yes, which enzyme is deficient? Answer would be tyrosine transaminase. And this is also called oculocutaneous tyrosinemia. You can easily remember by mnemonic torch, touch. Yes, T4 torch, T4 touch. Torch means vision, oculo. Touch means skin, cutaneous. So you can easily remember tyrosinemia type 2, TT, tyrosine transaminase, touch, torch. Touch, torch, oculo, touch, cutaneous tyrosinemia. Another name is Richner-Hanhart syndrome. So this is tyrosinemia type 2. Even if you don't remember this para-hydroxyphenyl pyruvate is produced, this step. If you don't remember, it's okay. But you must remember this, which I am putting in box, that this is tyrosinemia type 2. And you must know that this defect is in the metabolism of tyrosine. Yes, because questions sometimes they will ask tyrosinemia type 2 is due to defect in the metabolism of tyrosine. Tyrosinemia type 1 is due to defect in the metabolism of tyrosine. Alkaptonuria is due to defect in the metabolism of tyrosine. So this sequence is important. That congested diagram I have made purposefully. I know it becomes difficult to revise, but trust me, when questions are asked in integrated way, you can solve them easily. So I say, even if you don't remember this name, it's okay. This para-hydroxyphenyl pyruvate is converted to homogentisate. This step is not important, but this enzyme is important. Para-hydroxyphenyl pyruvate hydroxylase or dioxygenase. PPP. 1, 2, 3. Yes, 3. Tyrosinemia type 3. Tyrosinemia type 3. 3 times P. Yes, tyrosinemia type 3. And it is also known as neonatal tyrosinemia, para-hydroxyphenyl pyruvate hydroxylase or dioxygenase. Question would be asked, you will recognize 3 times P. Yes, that is tyrosinemia type 3. One more question, Hawkinsinuria, rarely asked but asked. In Hawkinsinuria, there is partial deficiency of para-hydroxyphenyl pyruvate hydroxylase. If this enzyme is deficient, tyrosinemia type 3. If it is partial deficient, then it is Hawkinsinuria. Hawkins, yes, cooker, famous, very famous cooker. Hawkins cooker is very famous and it gives swimming pool odor. How you will remember, your girlfriend is swimming and you are doing party and you are cooking in Hawkins. You are cooking. Girlfriend is swimming and swimming pool odor. Party is going, partial deficiency. Hawkins cooker is there. Now, homogentisate is converted to mallyl acetoacetate. Even if you don't remember this reaction, it's okay. Just remember that this reaction is catalyzed by homogentisate oxidase. 3 names for the same enzyme: homogentisate oxidase or homogentisate dioxygenase. And the third name is important, recently asked question: dihydroxyphenyl acetate dioxygenase. Really difficult to remember. How you will remember? Homo, Homo means two person, similar person. Yes. Now, di, two. So dihydroxy means two. Acetate, how many carbon atoms are there? Two carbon. Dioxygenase means two oxygen. So wherever you find two, yes, dihydroxyphenyl acetate dioxygenase, that is homogentisate oxidase. Okay. And if you find PPP, 3 times P, tyrosinemia type 3. If this enzyme homogentisate oxidase is deficient, that lead to alkaptonuria. I remember alkaptone like this, alkaptone. Kala. Urine turns black on standing. Most of time in clinical scenario, you will find that urine turns black on standing, and immediately without second thought, you mark the answer alkaptonuria. Yes, but other symptoms are also important. We found that this homogentisate is not metabolized. This homogentisate is oxidized to produce alkaptone bodies. Alkaptone bodies, black color. These alkaptone bodies accumulate in pinna, black color of pinna, nose of tip, blackish color. Yet it will deposit in intervertebral disc. Yes, intervertebral disc calcification would be there. Yes, pain, back pain would be there. It will deposit in sclera, black pigmentation of sclera. Yes. So blue discoloration of sclera, spot on the sclera. Yes. Urine turns black on standing. This deposit in skin. Yes, blackish color of skin. On hands skin, blackish color. And this is called ochronosis. This deposition lead to blackish color, and this is called ochronosis. What I said? Ochronosis. And we found one question that in alkaptonuria, ferric chloride test is positive, silver nitrate test is positive, Benedict test is positive, not so frequently, but just have an idea. So this is about alkaptonuria. Sometimes you will find that the patient is there in which alkaptonuria is there, and nappy of this child is blackish. You will wash with the help of soap, alkalization. Yes, soap is alkaline, and this blackish color become more and more dark, because this urine turns black on standing or alkalization. So if you wash with soap, you are alkalizing, so that will increase the black color. Now a question is asked on Garrot's tetrad. Garrot's tetrad include 4 disorders. Mnemonic is CAP. CAAP. Sometimes I remember sister is having white black pen. Cystinuria, sister is cystinuria. Alkaptone, kala, is black. Albany is white. Pen, yes, pantosuria. So sister is having black and white pen. That is Garrot's tetrad, mnemonic. Now we found that fumaryl acetoacetate is converted to fumarate and acetoacetate by fumaryl acetoacetate hydrolase. F4 first, F4 tyrosinemia type 1. So tyrosinemia type 1, in which fumaryl acetoacetate is deficient. F4 first, also known as hereditary hepatorenal tyrosinemia. This is most common type of tyrosinemia and resemble porphyria. So these are different types of tyrosinemia and alkaptonuria. Now, for screening of inborn error of metabolism, we do tandem mass spectrometry. Question. So till now we have discussed 2 aromatic amino acids. Those are phenylalanine and tyrosine. And these are really, really important, really complicated. I have tried to simplify with the help of mnemonic, but revise it once more. Yes. Now, tryptophan, aromatic amino acid. Yes, this is aromatic amino acid. We found that tryptophan is having very large bulky side chain, and this side chain is called indole ring. Indole I remember as baby doll. Baby doll, yes, so many fans are there and all fans are trapped. So you can easily remember so many fans, tryptophan, baby doll, indole ring is having. This bulky side chain you can't synthesize. When you can't synthesize, it is essential. We found that such a large aromatic side chain, no polarity, non-polar. So tryptophan is aromatic, non-polar, and essential. We found that in our body, this tryptophan is metabolized and tryptophan is converted to serotonin. Question is asked that precursor for serotonin is tryptophan. This serotonin is further converted to melatonin. Question is asked that precursor of melatonin is tryptophan. So tryptophan is converted to serotonin and melatonin. We found that serotonin is further metabolized to 5-hydroxyindole acetic acid. Hydroxyindole acetic acid in our body. So one pathway of tryptophan metabolism is towards serotonin and melatonin. And we found that second pathway of tryptophan metabolism is tryptophan is converted to 3-hydroxyquinuranin by multiple steps. This 3-hydroxyquinuranin is further converted to niacin. Niacin is vitamin B3. Vitamin B3, I remember niacin as Nia Sharma. So we know that 60 milligram of tryptophan give rise to 1 milligram of niacin by multiple steps. And in these steps, one step is catalyzed by quinuraninase. And this quinuraninase require B6 as cofactor. Active form of vitamin B6 is pyridoxal phosphate. So I can say that niacin is synthesized from tryptophan, and this niacin synthesis require B6. So if B6 is deficient, if B6 is not there, this step would not occur, niacin will not be synthesized. So when B6 is deficient, this 3-hydroxyquinuranin will increase. This 3-hydroxyquinuranin will be diverted towards synthesis of xanthurenic acid. So xanthurenic aciduria. So we found that B6 deficiency, this step is not occurring, and this 3-hydroxyquinuranin is converted to xanthurenic acid, xanthurenic aciduria. Question is asked that B6 deficiency lead to xanthurenic aciduria. Xanthurenic aciduria is seen in which of the following vitamin deficiency? Answer is B6. We know that B3, niacin deficiency lead to pellagra. Niacin deficiency lead to pellagra. Pellagra symptoms are 3D. Diarrhea, dementia, dermatitis. And dermatitis is typical castle-neck appearance. Image-based question, typical castle-neck appearance. Sun-exposed area, burning sensation would be there. They will describe dermatitis. So if question is asked, the person presented with diarrhea, dementia, dermatitis, typical castle-neck appearance, this patient may have. Yes, this is first question. This patient may have, answer would be B3 deficiency. So I told you pellagra, yes, diarrhea, dementia, dermatitis. But we found that a patient is there in which B6 is deficient. In this patient who is having B6 deficiency, niacin will not be synthesized. And again, it will present with, yes, pellagra symptoms. But how you will differentiate that this niacin deficiency is a consequence of B6 deficiency? If B6 is deficient, there would be increased xanthurenic aciduria. So if question is asked, they give clinical scenario that a patient present with diarrhea, dementia, dermatitis, and in clinical scenario they give that xanthurenic aciduria is there, then this is definitely pellagra, but this pellagra is not due to B3. In this, better answer would be B6 deficiency, because xanthurenic aciduria is there. We found that carcinoid syndrome. In carcinoid syndrome, more and more tryptophan is converted to serotonin. So serotonin increases. Serotonin is converted to HIAA. 24-hour urine HIAA will increase in carcinoid syndrome. When all tryptophan is used for this serotonin synthesis, tryptophan will not give rise to niacin. There would be deficiency of niacin, deficiency of B3 will lead to pellagra-like symptom. So differential diagnosis of pellagra is carcinoid syndrome. In carcinoid syndrome, again pellagra symptoms would be there. So if question is asked that a person presented with diarrhea, dementia, dermatitis, typical Castle-Neck appearance, and 24-hour urine HIAA is increased, in this pellagra is there, but this is due to carcinoid syndrome. Better answer would be carcinoid syndrome. There is a disorder called heart-nub disease. Heart-nub disease. You can easily remember that we are talking about baby doll, Nia Sharma, yes, car scene, scene of car. Yes, how you will remember? Yes, HIAA, Haya, Sharm or Haya. In Hindi, sorry to be in Hindi, ऐसी मूवी बनाई, such a bad movie, they don't have Haya, Sharm. तो याद रहेगा कि carcinoid HIA is increased. So when you will hear all these things, your heart would say nup, heart nub disease. So this is a misrelation of heart nub disease with pellagra. Okay. So heart nub, A for autosomal, R for recessive disorder, T for tryptophan, and U for neutral amino acid. So in heart-nub disease, tryptophan and neutral amino acid absorption is defective in intestine and renal tubule. So we found that in intestine and renal tubule, tryptophan and neutral amino acid will not be absorbed. This is autosomal recessive disorder. And when this renal tubule will not be able to absorb tryptophan, tryptophan will come in urine. So there would be amino acid urea. Amino acid urea. And when tryptophan will be excreted, will not be absorbed, tryptophan deficiency, tryptophan will not be converted to niacin. Niacin deficiency will lead to pellagra. So name itself tells you AR autosomal recessive, T for tryptophan, and U for neutral amino acid, P for pellagra-like symptom. A question was asked in Jipmer that mutation in heart-nub diseases SLC, yes, 6A19 gene mutation, Magapit. So this is heart-nub disease. Now differential diagnosis. Yes, if question is asked and they give the clinical scenario in the form of pellagra, diarrhea, dementia, dermatitis. First of all, you will search for HIAA. If HIAA is there, yes, it is carcinoid syndrome, scene of car, haya bhi nahi aayi, carcinoid. If xanthonic acid is increased, B6, SIX6, xanthonic aciduria. If question says that autosomal recessive disorder, amino acid urea is there, that is heart-nub disease. Now, after hearing so much of things like this, heart-nub, car seed, baby doll, Nia Sharma, yes, you said maza aa gaya. No, maza nahi lena, jada maza nahi lena. If maize is staple diet, in maize, tryptophan is found in low amount. So if you are taking jada maza nahi lena, otherwise tryptophan would be low, niacin deficiency would be there. So they will give dietary pattern and they will ask what is the diagnosis. Am I rotate? If I am rotate, that is B3 deficiency, niacin deficiency. If they give simply that diarrhea, dementia, dermatitis, or maize is staple diet, answer would be B3 deficiency. And in this question, a person presented with diarrhea, dementia, dermatitis, typical Castle-Neck appearance, there is autosomal recessive inheritance, defect in absorption of tryptophan or amino acid urea, you will mark the answer heart-nub disease. So these are differential diagnosis. We found that tryptophan absorbs light at around 260 to 80 nanometer. If there is a function, if baby doll is going, baby doll would be in limelight. So maximum light absorption by, yes, baby doll, tryptophan. So aromatic amino acid absorb light at around 260 to 80 nanometer. We have discussed tryptophan, phenylalanine, tyrosine. They are aromatic amino acid. They absorb light at around 260 to 80 nanometer. Question was asked, replacing alanine by which amino acid will increase UV absorption protein at 280 nanometer? That would be tryptophan will absorb light. So mnemonic, wherever you find aromatic ring, there are chances that it will